All right, well, it is 11:30 and I know we have so much great information to share. So again, if you just joined us, if you wouldn't mind just taking a brief survey before the presentation, your feedback is really important to us. But I would like to welcome you all to our first webinar for the Waukesha County Heroin Task Force Prevention Action Team. We're all excited to be here today and share this information with you. My name is Ashley. I am the Executive Director of Your Choice, and I will be your MC today. So if you have any questions or anything during the presentation or having struggles hearing or seeing, feel free to drop that in chat and I will try to help you with that. Like I said, this event is brought to you by the Waukesha County Heroin Task Force. And I have a little statement that I'm going to read provided by our wonderful chair, Mary Simon from Aleve. So on behalf of the Waukesha Heroin Task Force, we'd like to welcome you to today's webinar. Thank you so much for joining us. For those of you who may not be familiar with the Heroin Task Force, our vision is to reduce the impact of the opioid epidemic in Waukesha County through implementing a collective community approach to 4 priority areas. Those would be prevention, harm reduction, treatment and recovery, and data and reporting. The task force is comprised of representatives from Waukesha County Health and Human Services, community agencies, healthcare providers, law enforcement, schools, and individuals affected by the heroin epidemic. We offer quarterly community gatherings that are focused on educating members on topics that may impact their work or lives and opportunities to become actively involved in our action teams. This webinar is brought to you by the Prevention Action Team. The logos of the partners are on the screen, so you can see all the great people who have worked to put this together. Our goal over the next year is to offer additional educational opportunities to other groups to increase awareness and provide skills to assist them in effectively addressing substance use in their world. If you are interested in joining our efforts or would like to be placed on the Heroin Task Force email list, please indicate that on your survey and we will reach out to you directly. We hope you enjoy today's presentation. So again, thank you so much for being here and to all these community members for putting this on today. Just a few housekeeping items. This is a webinar presentation, so we won't be able to hear or see anybody. So again, if you're having a hard time hearing or seeing the presenter, feel free to drop it in the chat box and I will try to assist you with that. If you have questions for any of the speakers, we ask that you put the questions in the Q&A box. You should see it on the bottom or top of your screen, wherever your little toolbar is. That way we can kind of manage those questions. If they get put in chat, sometimes it's hard to go through them because they get lost in other conversations. And then we are offering free CEU credits for attending today's webinar. So if you are interested in that, make sure you complete the survey at the end. When you leave the presentation today, that survey will pop up. And I'll remind you again at the end. So with that, I am going to welcome our first presenter today. I'm going to take off my screen here. Maybe. There we go. Our first presenter today is Dr. Jessica Page, who is with Froedtert and the Medical College of Wisconsin, and she is the outpatient pharmacy manager who supports the retail pharmacies within the Froedtert Health Network. Jess has spent her entire professional career in community pharmacy dedicated to helping patients as an easily accessible healthcare provider. Her passions include opioid overdose prevention, pharmacy operations, and staff development. So please help me welcome Dr. Jessica Page.
Thank you so much, Ashley. And thank you everyone for joining. I'm gonna full caveat that I got switched rooms right before this meeting and the lights keep going out on me. So if I go dark for a minute and stand up waving my hands, that's what's going on there. But thank you for joining. Want to kind of start our presentation today by talking through A high-level opioid overview, kick us off by getting a better understanding of how opioids work in the body and why they're addictive. And then I'm going to pivot a little bit and talk for a while about some non-opioid pain medications that are available to patients. And then kind of wrap up my section by talking through strategies that can be used when a patient is prescribed opioids to ensure that they are handling them in a safe manner. So kicking off with that opioid overview. So high level, opioids are a class of medications that are actually found naturally in a plant, the opium poppy plant, and that's a picture of it there on the screen. Because of the natural sourcing of these medications, they've actually been around for an extremely long time. Data shows that there was some form of opioids or opium dating back to as far back as 3500 BC. You could sometimes hear this referenced in like kind of modern movies and pop culture that reference back to the, past time errors, the milk of poppy plant or opium, etc. They work by attaching to what are called opioid receptors. These opioid receptors are located on nerve cells that are primarily found in the central nervous system, the CNS, which is comprised of the brain and the spinal cord, and then also the gut. So these opioid receptors, the opioid medication literally attaches to the receptor. And what this ends up doing is blocking a pain signal from traveling up to the brain. So the brain has no recognition that pain happened at that site. Some examples of opioids, most of these you're probably familiar with, if not all of them, but oxycodone, hydrocodone, also known as Lorcet, Norco, or Vicodin, hydromorphone, brand name of that is Dilaudid, oxymorphone, Opana is what a lot of folks know that as, morphine, fentanyl, heroin, and then codeine. Obviously, some of these prescription, things like heroin, not prescription medications. So to kind of get an idea of the addictive nature of these meds, it's important to understand their side effect profile and what side effects we end up seeing in the body. So the sources of side effects of opioids tie directly to where we see those opioid receptors. And as I mentioned, you're going to find those in the central nervous system, so the brain and spinal cord, and then the gut. So your side effects directly relate to that. So in the gut, we see that constipation, nausea, and vomiting that a lot of folks hear about in relation to taking opioid medications. And then in the central nervous system, in the brain, you see a sedation, so tiredness, and slowed breathing, or respiratory depression is what it's sometimes caused. This slowed breathing, respiratory depression is what leads to overdoses and deaths, is that a patient essentially usually ends up decreasing breathing to a point of no survival or brain death. You also see with relation to these medications that dependence, tolerance, and addiction that we've talked about. And a lot of that is directly related because it works in the brain and of course the source of the medications and how they work in the body. So talking more about that addiction that happens with opioids. So why do people get addicted to opioids? High level, some patients just feel relaxed, happy, or that high feeling when they take an opioid medication. The relaxation could be an unexpected side effect, or it could be that sedation side effect that we talked about that can make folks feel happy or feel relaxed or happy with the medicine. The base way that opioids work is to remove an unpleasant feeling, that pain feeling. So that in and of itself can be addicting. If you're sitting there miserable in pain and this medication removes that, that can be something that you constantly want to go back to. So even if there's not any of those additional side effects happening, just the removal of the pain feeling can be an addictive thing. With that, opioids end up kind of tricking patients into believing they're necessary to survival. And the way that this works is our bodies are created and triggered to believe that pain is a sign of damage to the body and could be leading to bad effects in the body, damage, death, anything like that. And so if you remove that pain feeling, patients are naturally going to get this dependence and feeling that they have to take the medication for survival. So that's where that dependence starts to get created. From there, opioids end up actually diminishing their effects in the body the longer time you take them. So this is where you see tolerance start to kick in. And the reality is this happens because your body responds to those opioid receptors being blocked by creating more opioid receptors. And so to get that same level of pain relief, you have to increase the dose more and more over time. And so that's that tolerance that you hear of and why you might hear that patients keep getting increased on their opioid medication. Then with all of this together, patients can end up developing that compulsive need for that medication that we kind of call addiction, and where addiction really kicks in is all of a sudden I feel like I have to take this medication. It's essential for me to feel good and essential for me to survive, to be able to operate my daily life. So that's dependence leading into it. And then I need more and more to get that same reaction and that same response. And so that's where that, like I said, that compulsive need and that need for more and more comes to that kind of addiction head. What we see in reality is that about 1 in 4 patients that are using long-term opioids for truly legitimate medication needs end up struggling with addiction at some point down the road. Okay, so kind of pivoting, we're going to talk about some options of medications that can be used to help with pain that aren't opioid based. So don't quite work in the same mechanisms. I'm not going to go, recognizing you guys aren't all pharmacists out there, aren't all doctors. I'm not going to go super in depth, but kind of high level talk about some of the medications that are available to our patients that are not opioids. So the first class that I'm going to talk about are the over-the-counter medications. So these are medications that a patient can walk into most pharmacies and receive without any kind of prescription. So they can self-take the medications. So probably the one that most of us know the best is acetaminophen, brand name Tylenol. Some of the primary uses of Tylenol could be arthritis pain, lower back pain, or migraine medications are some of the ways that Tylenol work the best and some of the pain points that Tylenol can work best. Of note, some opioid medications have Tylenol already mixed into them. And Tylenol definitely does come with a side effect profile that can be dangerous, especially if the patient is struggling with other addictions such as alcohol use. And that is because the Tylenol is processed through the body using the liver. So some folks will hear, well, I can't take more Tylenol, or I can't take that. And it might have to do with their liver function and how well their liver is working in their body. The next group of medications that, again, I believe are pretty familiar to most people are Motrin, Advil, and Aleve. So Motrin and Advil are the brand names of what's called ibuprofen, and Aleve is a brand name of naproxen. Now, interestingly, both of these medications in lower doses are available over the counter, and in higher doses are available by prescription. By far, the best use of these medications is arthritis. Now, that being said, they work to decrease what we call inflammation or swelling. And so they can help for more acute injuries as well. So injuries that cause swelling, let's say you twist your ankle, they can also be very beneficial for those sorts of pain points. And the last group of medications that are available without that prescription and over the counter are what I call topical medications. And so topical meaning that they can be applied to the site that is in pain and will work only on that site rather than in the body as a whole. By nature, because these medications are primarily just working on the site they are applied to, they usually come with a lot less side effects, which is great. But because they're applied externally, meaning on top of the skin, not inside the body via the blood system, etc., they sometimes don't have as strong of an effect as what we call systemic medications that you take by mouth. Some examples here, lidocaine, that actually used to be a prescription-only medication, and more we're seeing it approved as over-the-counter. So we see that available now in patch form and in ointment form. Another medication that used to be prescription-only but is now available over-the-counter is called diclofenac. diclofenac cream or Voltaren. So this medication is actually in that same class as the ibuprofen and the naproxen, where it works on the swelling in that area, but it topically does it, so very local to the site of pain. And then the last one are the menthol creams and ointments. So these are your kind of traditional icy hot, biofreeze, Bengay. All of these products, again, work pretty well on arthritis. They can work well on local, what we call nerve pain. So whether it's pain or that tingling that people talk about. The menthol in particular is kind of an interesting way that it works. That type of a product applies and it almost creates a different sensation that distracts the nerves from realizing that they are in pain and they're also experiencing pain. So the whole goal of that is to kind of focus on the other sensation that the menthol is creating on the skin, and the body doesn't focus on the pain as much when those are applied. So as I mentioned, all of those medications we just spoke about are all available over the counter without a prescription. Now let's talk about some of the prescription medications that can be used that are not opioid in nature. So the first class are actually, again, going back to the same class as that ibuprofen and naproxen. So the Motrin, Aleve, Advils. There is also a group of them that are available only as prescription. And the reason for this is that they're a little bit stronger and could be a little bit more dangerous if taken without a provider kind of monitoring them. So we see diclofenac, meloxicam, and what's called celecoxib or Celebrex in this group. These, again, we've talked about it a lot, but these can help with that arthritis pain. They usually work best if they're kind of taken on a regular cadence, not necessarily at that moment when you're having pain. And then they can also support like a local trauma related pain. So like we talked about with the ibuprofen and the naproxen, because they're anti-inflammatory or anti-swelling, if you have a more acute pain, trauma related pain, they can be very effective against that. The Celebrex is a little bit different than the others, but for purposes of this presentation, I put them in together. It can come with a little bit less side effects than the other medications. So more and more that's becoming popular just for the fact that you don't have as many side effects with that medication. And that has to do with the receptors and where they're at and how well it connects to those. Another class of medications that interestingly work very well for pain are classically called anti-seizure medications, and specifically gabapentin, brand name Neurontin, or pregabalin, which is brand name Lyrica. These medications actually work by acting directly on the nerves, so kind of similar to opioids in that sense. And so they work really well for that nerve pain. The reality is seizures, just like nerve pain, are caused by kind of rapid firing and overstimulation of the nerves. And so the same way that they work on seizures, they can help to minimize and decrease nerve pain for patients. So these have been found to be really, really useful for our patients who really struggle with that fibromyalgia that is nerve pain, nerve-based. We are finding as a caveat that these medications can be slightly addictive on their own sense. So gabapentin, for example, is often used as a recovery medication for addicts and is often used as a replacement to opioids, but there can be addictive natures to these medications as well. And honestly, much to how we talked about the opioids, they're working on some of the same systems, right? They're working in that brain, they're removing that unpleasant pain feeling, and so can still create that same addiction that we see with opioids, but usually not to the level and to the severity that we see with opioids. Antidepressants. So there is a group of antidepressants, well, actually a couple of groups of them, that they work very well as antidepressants, but because, again, they're working in that central nervous system, so the brain, the spinal cord, we're finding that they also have effects on some of those nerve pains. So duloxetine, also known as Cymbalta, or venlafaxine, also known as Effexor, both of those medications work very well, kind of similar to the gabapentin and the Lyrica. They work very well on those rapid firing nerves and to help squelch that nerve pain. Amitriptyline and nortriptyline are actually really old school antidepressants that are very rarely used as true antidepressants anymore. But what we found is that if they're used on a regular cadence, so once a day on on an ongoing basis, they can actually help prevent and decrease the severity of migraines that patients have. And then the last group of prescription medications that I'm going to talk about are steroid injections. So this is typically like a cortisone injection that is usually done directly in the site. This works best on joint related pain, right? So that's arthritis, can work for rotator cuff disease. These medications, as you know, these get kind of a lot of we'll call it press, where people know a little bit more about these. As you know, they can only be done so often, and over time, their effectiveness doesn't work as well. But they are still another option, especially if patients are having very localized joint pain, to be able to support that. Okay, so the last topic I'm going to kind of walk through here are safe strategies that you can use if you or a loved one are taking opioid medications. So first and very important is when you have an opioid medication on hand in your home, it should always be locked up. Even if you live alone, even if you believe there's no one in your home who has an issue, it's important to keep it in a locked cabinet. I cannot tell you the number of times I've heard of a teenager, for example, getting started on opioid medication because they found it in their grandparents' home or bathroom. They found it, my dad had surgery 10 years ago and still had opioids laying around. So it's extremely important that if it is going to be sitting in your home, that it needs to be locked up. So a locked cabinet or a secure area, obviously important for children and pets to not get to it, but also anybody that shouldn't have access can get to it, shouldn't be able to get to it. I have some examples, and Ashley will talk about this a little bit later in our presentation today, but I have some examples of what some lock boxes or bags are, and actually I believe we have some of these that are actually going to be available for free through the ADRC, but I'll let Ashley weigh in more on that later on. But as you can see, all of them come with some type of lock device and varying sizes depending on what types of opioids or how many. So a hospice patient, for example, who might be on a large number of opioid medications at end of life might need a larger lockbox on hand. I think it's pretty well known, but opioids should never be purposefully shared with anyone other than the patient. And then another thing that a lot of patients don't think about or don't realize could be important is keeping records of your opioid medication. So if you start with a prescription from the doctor with 30 pills, you should be recording how often you take the medication, and I would count back the number of tablets on a regular cadence, whether that's once a day, whether that's every time you take it. It can be a sign if some are missing and you don't realize it. So, 30 tablets of real tiny pills doesn't look much different than 25 tablets of really little pills. And so it can help to count back to kind of keep an eye. It also gives you an idea, am I increasing the amount I'm taking? So keeping a record of your medications can be really beneficial. And then the last area I'm going to talk about today is disposal. So a lot of focus these days on disposal of medications. The reality is any medications that are left over, not just opioids, if they're no longer needed, they should be disposed of as quickly as possible. But opioids carry even more of a risk. As I kind of referenced earlier, you never know who could get a hold of those years later or months later. So I always recommend disposing of this very quickly. Some options. The Department of Justice has drug take-back days. We're very fortunate we get 2 of these in a year, usually around here. We actually have one coming up here on April 30th. Some of the Waukesha County locations of interest are listed on the screen there, spread out throughout the county. So coming up on April 30th, do a little bit of a spring clean out those medicine cabinets, get those medications ready to go and take those. There's no questions asked, nobody, reviews them or anything. It is truly just a disposal. You can also locate a medication drop box. So I've put a link in here, and I believe Ashley will have a link in her presentation as well that shows you some of the drop box locations. A lot of police stations, fire departments, and more pharmacies have these located with them. And then another option, if you truly can't get somewhere to dispose of these medications, are that you can self-destruct them. This is the less preferred, but still more important than keeping opioids on hand. So your way to get rid of this would be to dissolve the medication in water and mix it with what we call an undesirable item. So kitty litter or coffee grounds, and then you can throw them in the garbage. This will prevent the medication from being easily retrievable. It's not usually something someone wants to take, and it doesn't seep into the sewer system. So, the old school idea of flushing it, there's no risk here of it seeping into the water line. So very important to dispose of those medications quickly and in a safe manner. I'm going to go ahead and hand back to Ashley for our next presenters. Thank you for your time.
Thank you so much, Dr. Page. I don't know how you can remember all those names, but it sounds like a tongue twister to me whenever you talk about the medications, but thank you so much. It was so great. I want to welcome up our next presenter, Dr. Julie Rickert. Dr. Julie Rickert is a clinical psychologist and associate professor in the Department of Family and Community Medicine at the Medical College of Wisconsin. Dr. Rickert splits her time between clinical practice and education. Her clinical interests are diverse, ranging from peripartum around birth, mental health, to chronic pain, performance anxiety, and prevention of behavioral health problems. Her academic interests include communication skills and physician well-being. Dr. Rickert is the chairperson for the Forum for Behavioral Science in Family Medicine. So welcome.
Thank you. I'm so glad to be here. One of the things I just wanted to make sure everybody knows is I'm a clinical psychologist, not a psychiatrist. So that was a mistake on the flyer, and I apologize for not catching that. I've been interested in chronic pain for many years now as part of my job teaching physicians, young physicians, how to take good care of patients. I saw early on so many problems with conflict between physicians and patients, and really lovely, wonderful people with very serious opioid-related problems. And one of the things that I find really useful is to talk about it as being a result of the disease of chronic pain and the nature of the medications. And unfortunately, opioid medications are a very blunt tool for treating a very complicated problem. So I want to share with you a little information just so that you can understand how is chronic pain different from acute pain, and what are some different ways to think about it to help reduce the risk for addiction or misuse of medications in very good people. One of the things I did early on is I worked at a behavioral pain treatment center for people who had been taken off of opioids and were trained up in lots of other lifestyle changes that they could do. And we saw soccer moms and grandparents and many, many family members, many of which who had switched over to heroin when their doctors stopped prescribing their oxycodone, who really, at the end of the day, were just seeking relief of suffering. And so when you can focus on helping people get relief from suffering, you're going to be much better able to partner with them in assuming these new lifestyle changes that will make them so much safer. So just very quickly, and I don't know if I can get my screen to change here. There we go. One of the major problems that we have is that we expect chronic pain to work like acute pain. You injure your joint, the joint sends a signal up to your brain experiences that as a sensation of pain. Sometimes it's very brief and you can just continue with your activity. Other times the pain persists for a short period of time and you need to have some period of recovery. Your doctor may recommend that you ice it to reduce inflammation. They may recommend that you stay off of it, that you go on crutches or you have a brace. They may prescribe medications. And for acute pain, opioid medications may be very useful. Other medications might be muscle relaxers. They might be non-steroidal anti-inflammatory medications. There's a lot of things that we can do for acute pain. Your doctor may also recommend physical therapy, and over time, you can recondition, re-strengthen, but in other cases, sometimes people need surgery. But when pain persists over time, and the research varies a fair amount, whether it's 3 months or 6 months, but when it goes on and on, although for the patient, the pain feels the same, things are very, very different in the body. And then we need to deal with it very differently. So first and foremost, Dr. Page mentioned and alluded to this a little bit. There are some changes in what's happening both in the spinal cord and in the brain. So your spinal cord does a worse and worse job of dampening pain signals. We have a descending pathway in our spinal cord that says, hey, calm down, we got the message, we don't need any more signals coming up. When pain persists, that doesn't work as well. That medication duloxetine she mentioned does a great job of counteracting that, which is why we really want patients, whether or not they're depressed, to consider taking some of those antidepressants. In addition, your brain becomes more sensitive, and I'm going to come to that a little bit more. The other thing that happens is that pain is supposed to be a sign that you're in danger. And as a result, your fight or flight system gets involved. So people will talk about feeling more stressed when they have pain all the time. They may have more and more anxiety or more anger. And so for those of you who are caregivers, you may have found that patients with chronic pain can feel difficult to interact with. Good people become more argumentative, sensitive, frustrated, anxious. But the other thing that happens is that those emotions feed back and make the sensation of pain worse. And it is a terrible, vicious cycle for people to be in. The longer pain persists, the more brain areas get involved in processing pain, and the stronger the brain responds. Now, there's a very interesting thing that happens, and you're going to be speaking to a physical therapist after my presentation to you. And I want you to listen very carefully to what she has to say. The one thing that counteracts this is staying physically active despite the pain. There is nothing else that is more important for pain outcomes than staying physically active. So if you remember nothing else, please remember that piece. Now it's tricky because acute pain is supposed to make you rest, stay off the injured areas so that maybe that sprained ankle can heal up. But in chronic pain, it is essential that people engage in gentle, daily physical activity of some sort. The other thing that happens is people can develop pain in other uninjured body areas because they start to hold muscle tension in those other areas. So somebody starts with lower back pain, but they start to hold tension up here in the shoulder and neck area. And as a result, they start having headaches, or they'll talk about having buttocks or leg pain. And so learning how to relax, to let go of that muscle tension can get rid of secondary pain. And that's usually one of my earliest goals for my chronic pain patients. The other things is that there's just changes in how people live their lives. When people have pain, they have more problems with insomnia. They're much more fatigued during the day. They become less and less active, as we talked about. That reinforces and makes the pain worse. But also they're not doing the things that made their life worthwhile before. They become more isolated from others. They're not able to do the fun things. Their pain syndromes often are unpredictable. They have to cancel at the last minute. And other people just don't get it. They think if they just tried harder. And as a result, many patients become more and more depressed. As Dr. Page mentioned, we get used to our medications. People have less and less relief from their opioid medications over time. And once somebody can qualify for a chronic pain diagnosis, they're usually only getting about a 30% reduction in pain from their opioid painkillers. But of course, they want relief. They want 100%, right? Or at least 90%. They want to mostly feel better. And so this is extremely dangerous. So patients start to take their second doses more quickly, which is why those lock boxes are very nice. They start taking more and more medications. They add other things on. And a particular concern is if they drink alcohol with their opioid medication, now they're at real risk for having, potentially a health crisis or a death. Also, some of the anxiety treatment medications, benzodiazepines, if you take them with an opioid, put you at terrible, terrible risk for stopping breathing. Now, these patients are not bad patients. They are usually not trying to get high. They are simply trying to relieve their suffering, to get some rest, to just feel okay. So Dr. Page talked a little bit about physical dependency. If you take an opioid medication every day, you will become physically dependent. Just like when I have caffeine every single day. So my body expects it. If I don't have caffeine, I feel tired. I may have a headache. And those are signs that my body is physically dependent on caffeine. Well, people become physically dependent on their opioids so that when they don't have them, they feel sick and shaky. But that is not addiction. Okay? Not every patient who's physically dependent will be addicted. Addiction is when people have maladaptive behaviors related to their opioid use. And that could be escalating the dose on their own, taking other opioid painkillers, kind of like somebody else's fentanyl that's not prescribed for them, or even trying heroin. When they start to have problems with finances related to their chasing of getting these medications, and then lots of patients will have problems with relationships. And so those things, when there's a problem in behavior, that's when we start to use the word addiction. Another concerning problem that many people are not aware of with opioid medications is that in some cases, particularly when the medications are prescribed for things that opioids are not really indicated for. So opioids are not good for every type of pain. For example, if somebody has chronic lower back pain, opioids tend to predict worsening functioning over time. Dr. Page mentioned that nerve disorder, fibromyalgia, opioids over time make fibromyalgia worse. Whatever the reason, a certain number of patients will develop opioid-induced hyperalgesia. So although they care less about their pain when they're feeling that little bit of well-being from their opioid, it's not actually decreasing their pain. In some cases, it's increasing their pain. And at our pain clinic, as we withdrew people off their opioid medications, we found about 15% of them had a dramatic increase once they were over the withdrawal. The withdrawal is always bad, but once they were over the withdrawal, they had a dramatic increase in pain. And we believe that almost all of those patients had that opioid-induced hyperalgesia. Now, so we take pain patients, they come in, they're in conflict with their doctors, they're chasing the type of relief that the medications we have cannot give them. And now we're asking them to be more physically active. And I'm going to tell you a little bit about some other things that might help. And it's hard. Patients are resistant. They're like, physical therapy makes me worse. Well, not necessarily if it's done the right way. But developing that trusting relationship with the patient so that they can start to make those lifestyle changes to make pain more tolerable is so important. So I mentioned earlier, patients are getting in trouble by chasing that short-term relief. They take too much pain medication, building tolerance without getting more relief. They are taking other medications like anxiety medications and drinking alcohol. And they become more inactive, making their bodies weaker and they make their brains more sensitive to pain. And so we have to ask them to make a choice between staying the same, is this working for you, or making some changes, even if those changes might feel a little risky. So there are some very predictable steps that can be helpful. And the first thing is to partner with their doctor. If they have a doctor that they feel respects them, even though they may have done some troublesome behaviors, these aberrant behaviors can happen even in very, very good patients. That trusting relationship helps them be honest about what's going on. And then starting to do these other behaviors that really predict the best outcomes. And so while sometimes patients aren't talking about their pain decreasing a lot, when you have a good chronic pain lifestyle, the quality of life scores go way up and depression scores go way down. That's normally what we're looking for. Now, some of these work better than others. As I said earlier, daily gentle physical activity is the best predictor of improved outcomes. But lots of times patients are so scared to start. So we start using heat or ice, relaxation strategies, having good ergonomics. I had a patient once who had had a couple of neck surgeries, and she and her husband sat kitty corner to the television. We just moved their chairs side by side. So they sat next to each other and looked at the television, had the television at the right height. And she had a lot less neck pain when her favorite activity that she did with her husband wasn't something that caused her to assume a position that aggravated her shoulder and neck. Working on finding ways that they can socialize now that they can't do the things that they used to do. There are some changes in diet and drinking and other health behaviors that can improve outcomes. And then just starting to feel like, yes, I can do some things about my pain, and becoming an active participant in making things better. Most patients have to make quite a few small changes before they start to get some relief. Patients should have a goal, and the goal needs to not be reduction of pain. It needs to be, I would like to be able to spend time with my grandchildren. I would like to be able to quilt. I would like to be able to watch a football game. Those are great goals for a pain patient. I'm going to just skip right over this because I believe that our physical therapist is going to talk about this, but I can't repeat it enough how important that physical activity is for patients. Another really important thing is called activity pacing. And this is very important for preventing pain flares. If any of you have dealt with somebody with chronic pain, what you've probably found is when they have a good day, they do all their laundry, or they clean their bathrooms, or vacuum their floors, and the next day they're back in bed. My patients notoriously, if they have to do a functional capacity evaluation for workman's comp, it'll set us back 3 months sometimes in their recovery from their chronic pain syndrome. So doing more activity on bad days and doing less activity on good days helps people make gradual improvement in functioning over time. Learning how to say no is very important. I already mentioned ergonomics, and then managing emotions. So lots of chronic pain patients will work with behavioral health providers to control their fight or flight response, reduce their depression. Behavioral health is not the only way to do that. You can work with your physician, try an antidepressant. You can watch YouTube videos about relaxation. Daily walking has a very strong impact, almost as much as that lowest dose of an antidepressant on mood. And socializing has good impact, as well as spirituality and prayer. Reducing brain sensitivity, in addition to the physical activity, quitting smoking can reduce pain by as much as 30%. That is huge. That's as much as taking an opioid medication. The only problem is it doesn't work right away. And so patients have this terrible withdrawal from nicotine while they're going through the process. But in the long run, it's generally worth doing. Caffeine is a problem. Pain patients often are extremely fatigued. But the caffeine causes them to have more muscle tension, but it also increases that fight or flight response. And as I mentioned earlier, alcohol is a huge problem. Unfortunately, alcohol in the short run does cause a little bit of pain relief while you drink. You know, think about those old Westerns where they took a shot of whiskey before they cut the bullet out of the person's leg. It relieves pain in the short run, makes pain worse in the long run, and is absolutely dangerous when combined with any opioids. If somebody is taking an opioid, alcohol is not an option. And then pain patients often are afraid to do things that are fun because they can no longer do the work that they were doing. And so learning how to let go of guilt and have positive life experiences again is really important. They should have a difficult day plan. I love that Dr. Page went through some of those topicals. Those are really useful for lots of patients. Using ice or heat, relaxation, stretching, talking to somebody you care about, or anything distracting. I love adult coloring books for my pain patients. Every person's plan is going to be different, and that's okay. Each patient should develop their own over time. And once they're doing it, this is one of the hardest things, you'd be surprised. They need to keep doing what works. I had a patient once come in and said, that TriLife program didn't work for me. And I'm like, well, gosh, at your 1 year follow-up visit, you were doing great. And I said, when's the last time you did your relaxation? And they always look up in the corner as if it's going to tell them up there when the last time they did it is. And I know that they stopped the walking and the relaxation and the Tai Chi and the positive mental attitude and the kind of Zen, calm style of life that makes such a difference. I'm going to try to wrap up here. So for caregivers, just know that patients with chronic pain can feel very difficult to care for, not because they're bad people, but because their disease pulls for that fight or flight response out of them. So when you understand that their unpleasant behaviors are symptoms of the illness, this can sometimes help. If they're irritable, it's likely due to pain, sometimes due to the medication. I don't think opioids bring out the nicest qualities in people's personality, or insomnia. So sometimes you can just reflect the underlying cause. I can tell you're having a hard day today. Hold on to your kindness, don't take it personally, and encourage discussion about non-pain topics, grandchildren, church. Couple of other things you can do. Muscle chilling makes pain worse. So help prevent your patients from getting chilled. Make sure they wear hats and warm coats when it's cold out. If they're going to go for a walk, put their sweatshirt in the dryer before they go. Encourage that gentle physical activity. Prevent those big increases in physical activity that cause pain flares. Encourage non-medication coping, belly breathing, stretching, heating pads or ice, distraction, counter pressure. You can use a tennis ball, or there's a piece of equipment called a Theracane, but they need to be taught how to use that by a physical therapist because they can put too much pressure and re-injure the area. And some essential oils, peppermint and lavender essential oils do have some data for improving people's functioning. And to look at the environment to see if screen locations and other ergonomic factors are making things worse. So we're going to save those questions till the end, and I am going to hand things over to Dr. Edwards, who's going to share all the important things physical therapy has to offer.
Thank you so much, Dr. Rickard. It was amazing. All the information you shared with us. Next, I would like to welcome Dr. Julie Edwards. She is Doctor of Physical Therapy at Pro Healthcare with over 30 years experience, which includes serving as the physical therapist on an interdisciplinary team in a pain management center. Julie is passionate about preventing disability and opioid addiction with smart physical therapy. So welcome.
Well, thank you. I'm honored to be with you all virtually today. Let me pull up my slides. Okay, let's see. So we're going to share the screen. And let's get a good view here. How about, Oh, so a little issue with the toolbar being over. Let's see here. If I can pull this down, go like this. Thank you for your patience. So we're gonna go view, reading view. How's that?
That looks great.
Can you hear me okay?
Yep.
Okay. Well, my intention for the next 20 minutes is to share some stories from my physical therapy practice to empower you to start the conversation. What would it look like for you to try physical therapy as a safe and effective alternative to opioids? I'm going to also share some non-pharmaceutical strategies to decrease pain. And I did create a handout with links to some of the resources and references that, that I'll be mentioning in the next 20 minutes. And I'd like to start with a story. A 30-something-year-old patient with chronic low back pain, whom I'll call Jennifer, shared her story with me at her initial physical therapy evaluation. She shares she's also in a drug rehab program, and that's going well for her, helping her to get back on her feet after she served 2 years in jail for stealing from her employer to buy heroin. And looking at her, you would never guess she was a heroin addict or an inmate. She shares it all started with Vicodin for her low back pain. When she couldn't find a doctor who would prescribe opioids for her, she found another source. She tells me that her husband divorced her and was awarded custody of their 2 young children around the time that she was incarcerated. Well, Jennifer did great with physical therapy over the course of about 10 weeks. To start, I recommended a TENS unit for her to begin to change her brain's habitual processing of her low back pain since it was chronic. As a component of her PT home program, she used her TENS unit for 30 minutes twice a day for about 6 weeks. During her initial physical therapy evaluation, I identified movement impairments involving her SI joint, her sacroiliac joint, that we were actually able to greatly improve, actually correct with manual therapy, soft tissue and joint mobilizations, movement retraining, including posture and body mechanics training, and progressive strengthening to make real changes. So we're not just providing symptom relief. A plateau, Jennifer was able to perform all instrumental activities of daily living and manage her pain on a 0 to 2 out of 10. She no longer needed the TENS unit, but she'll keep it in a drawer in case she has a flare up. I am aware that Jennifer and her husband remarried. This story hasn't happened. Jennifer is just one example of many patients who could have managed their pain with physical therapy without trying opioids.
Julie, can you, it's kind of a little muffled now.
Okay. My microphone is better?
Not much.
I don't know what else I can do. It's muffled.
Yeah, just a little. Is it on your headphones?
Yeah, I'm holding it here. Is this better?
That's better. Yes.
Okay, I'm going to hold my microphone right here. Sorry about that.
It's okay.
Okay. So opioids are largely ineffective for low back pain. PT, including exercise, is cited by the CDC as effective. Physical therapists must document patient progress towards measurable goals in order for insurance companies to pay for our treatments. And our patients do improve how they move with less pain and most often meet their functional goals and can get back to doing what they do. So in Wisconsin, you don't need a doctor's referral for physical therapy. Now, this is in regard to Wisconsin state law. We still have work to do at the national level. Medicare Part B still requires physician referral. Most insurance companies will now cover physical therapy without physician referral, but patients should always check and make sure that the PT that you would like to see is a network for you and that you can afford the rates if you have a high deductible. Physical therapists have about 7 years of school and now graduate with a clinical doctoral degree in physical therapy. I graduated with a bachelor's in 1991, and I earned my post-professional doctoral degree 8 years ago. We're trained to do medical screening to rule out red flags, to make sure the patients are appropriate for PT, and if not, we refer out to an MD. I also included a PDF guide that will be emailed to you, how to talk to your doctor about pain when it's more appropriate to see a doctor first. Physical therapists are movement specialists. Rather than masking pain as a symptom, you have the option to see a physical therapist and look for the root cause contributors to your pain. Patients can always be asked to be referred to a PT. They can ask their doctors to be referred to PT. Now, the patient in this photo does not have tight hamstrings, but maybe he did when he started PT. So other side effects of opioids may cause dizziness, and drug side effects may increase fall risk. On top of the vicious cycle of pain and weakness, so you have pain, you do less, you get weaker, and so you have more pain and do less. PT can break that cycle. We can problem solve with patients to figure out a stepwise approach to help improve strength and balance. Also, for some patients, PT can help to correct muscle imbalances that contribute to mechanical problems and pain with movement. So here's another story. Paul can no longer stand up straight or walk more than 50 yards. He walks like he's sitting. The muscles that flex or bend Paul's hips got stiff, then permanently shortened, called hip flexion contractures. He can't lie flat on his back without increased low back pain, so he sleeps in a recliner. Paul may wish that he had been referred to physical therapy years earlier or had attended this talk to learn about how important it is to stretch the muscles on the front of the hips before they permanently shorten. The good news is, if caught early, hip flexor muscles can be stretched and permanent contractures can be prevented. Now, I told you I'm passionate about prevention. My gift to you for attending this talk: by listening to Paul's story and stretching your hip flexor muscles daily and not sleeping in a recliner or a Craft-O-Matic bed, you can prevent hip flexor muscle contractures, and you will never walk like you're sitting in your golden years. If I can spread this message to everyone, then no one will be walking around like they're sitting when they're in their late 70s, 80s, and 90s. You can maintain normal length of the hip flexor muscles by standing tall and contracting your buttock muscles. They work opposite the muscles on the front of the hips. So you've all been sitting for a while. So right now I'd like you to stand up and stand up tall as you are. So if you're 5'8", be 5'8". Pretend that you're at your medical checkup and the nurse is measuring your height. You don't want to lose any height. Like a string is lifting your head to the ceiling. Now reach, we all need to reach more and go up on your toes. So rising up on the toes strengthens your calf muscles, which we need for fast walking. Now I'd like you to repeat that. And I call those get-ups, and you can get up and move, do 10 of these after sitting for an hour. They're also reminiscent of touchdowns, where even if your team isn't winning, you could do this to break up long sitting. And here's another stretch, as long as you're still standing. Step forward with your left leg. If you need to hold on to something for balance, that would be fine. And reach up with your right leg. Your right heel should be back, and keep that heel down so you're also stretching your calf muscles. But by reaching, it keeps you from bending forward, because if you bend forward, you might think you're stretching your hip flexors, but you're not. And I did include these exercises in the handout that's going to be emailed to you. So if you know somebody who walks like they're sitting, rather than advise them to buy one of those $800 walkers you saw on TV, start the conversation. What would it look like to you to try physical therapy? Physical therapists are movement experts who improve quality of life through hands-on care, patient education, and prescribed movement. Quick story about a patient with neck pain. Mary. So Mary's grandson accompanied her to her physical therapy session. I explained to Mary her aching neck muscles were triggered by her head on neck forward head posture. She turned to her grandson playing a game on his phone, pointed a finger at him, and said to her grandson, you need to put your head more on top of your neck. And he did, she was right, but I didn't want to be responsible for starting a nagging relationship between a grandmother and her grandson. So I said, I'm going to lay down the ground rules right now. When you see Daniel with his head forward over his phone, you role model your best head on neck posture, smile and wink. Got it? So we all laughed. Often physical therapists are better suited than family and spouses for coaching improvements in posture. But feel free to try the role model, smile, and wink method. So think of the nervous system as the body's alarm system. Chronic pain that lasts 3 months or more, once the tissues have had enough time to heal, is less about tissue damage and more about the sensitivity of the nervous system. The alarm system, the brain and peripheral nerves, is supposed to be triggered when we're threatened and we need to do something about a problem, like stepping on a nail. And then after we go to urgent care and get a tetanus shot, the alarm system is supposed to return to a normal, quiet level. However, in one in 4 people, the alarm system does not settle back down and it stays extra sensitive. If pain lasts beyond the normal healing time, it's likely due to a faulty, extra sensitive alarm. Like a faulty dashboard engine light, even though the engine is fine, it's super annoying. So before pain, lots of room for activities. After pain, with extra sensitive nerves and low threshold for triggering the extra sensitive alarm system, may leave little room for activities. A helpful analogy is a house alarm that's supposed to go off when someone breaks a window, but the system is set so sensitive that it goes off when a leaf floats by. Is there a real threat? No, the system is just too sensitive. This is the same for the body's alarm system, your nervous system. Hurt does not equal harm. Severe pain does not equal severe tissue damage. Someone with fibromyalgia may have a normal MRI, but is truly suffering with severe pain. All pain is real. Pain is complex. This slide shows functional MRI brain scans of a woman with chronic pain at rest in the top row, and then in the lower row, the 3 brain scans show more global connections in her brain, the red, when she moves. Pain plus emotion equals suffering. Anxiety is like pouring gasoline on the fire of pain. Fear and anxiety are cousins of a sensitive and nervous system. Threats to safety trigger emotions. Fear, anxiety, catastrophizing. 90% of low back pain episodes clear up on their own, and this is reassuring. So let's reassure each other to keep gasoline off the fire of pain, especially for acute pain. If low back pain is not going away, start the conversation. What would it look like for you to try physical therapy or see your doctor? Everyone wants an MRI, I find, but 85% of low back pain does not correlate with MRI. In fact, research shows unnecessary imaging is correlated with poor outcomes. Patients feel like their current pain problem is due to a structural problem that needs to be fixed by surgery or may never improve. They likely had the problems years before they had pain, and if they improve a few things about how they move, they can return to activities without pain, even with no change in structural problems. Many studies have been done where they gave MRIs to people with no pain and no symptoms. For example, 60% of 50-year-olds with no pain and no symptoms were found to have disc bulges on MRI. As you can see by my graph, the likelihood to have a disc bulge increases with age, and this trend is true for many structural problems. Patients may have an MRI study that shows a disc bulge, but it may not be the cause of their pain, and they may not need surgery for it. Words can harm, and it may be harmful to tell patients something is torn, ripped, herniated, bulged. So rather than telling a patient they have a degenerated spine, we can tell them that they have wrinkles on the inside. The healthcare model is moving away from a pathoanatomical model to guide our clinical practice. Instead of looking for problems with structure, which can be explained by imaging of anatomy, we're moving toward a practice looking for root cause contributors, including lifestyle factors. Often the problem is with the physiology and how body systems work in harmony with each other. For example, the standard American diet contributes to chronic system inflammation, which may contribute to a sensitive nervous system. Words that heal. You're going to be okay. Reassurance to dial down the alarm. And please do not tell someone with chronic pain, the doctor told you your pain's all in your head. So I shared on the handout that you'll be getting by email from Ashley, a link to Adrian Lau. He's a PhD physical therapist, and he's a leading expert on pain neuroscience education. And this 3-minute video may be appropriate to share, or if you're just interested in more information. This particular video, Understanding Pain and What to Do About It, if I can skip that up. Understanding pain and what to do about it in 5 minutes. This is actually a 6-minute video. I've watched this with hundreds of patients to get on the same page with patients, chronic pain patients, about rewiring the brain. And I did include this link as well. Pain neuroscience education is treatment. Functional MRI studies have demonstrated significant decrease in pain representation from the red blobs on the prior brain transplant following pain education by physical therapists. For each of the issues of chronic pain, and your brain may be overprotecting you by guarding. Some patients manage pain by avoiding everything that increases pain. Teachers can teach patients how to move less pain and get started on the road back to doing activities that give up.
Dr. Edwards, the sound is off again. Sorry. It was really good.
Very different. Is it okay?
It's quiet again. Yeah.
Oh dear. I'm so sorry.
It's okay.
Everything works good in practice. Well, one of my patients found this pain severity scale. Is it okay?
Yes. Yep.
Okay, and shared it with me. She found it on Pinterest. And if you're required to talk to your, if you're interested in using this to talk to your healthcare provider about pain, you can just search for it on Pinterest. You search for pain severity scales. Let me slide this up so you can see. And most patients find it more useful than the sad and smiley faces. This scale describes the pain experience. For example, a 4 out of 10 is, I'm constantly aware of my pain, but I can continue most activities. So of course, everybody wants to be pain-free, but that may be an elusive goal. So once we reach the age of 50, we have mild aches and pains. The 2 out of 10 pain experience, I have low level of pain. I'm aware of it. I'm aware of my pain only when I pay attention to it. That may be a more realistic goal rather than that goal to be pain-free. And so I can tell them that, you know, you're here, but what we can expect from participating in physical therapy is moving you down here so that most of the time you can block it out. Depending on the condition and the patient, teaching patients that no pain, no gain is bad advice may be safest, but some chronic pain patients are already avoiding all movement and may need to move even though it hurts at first. Pain should subside 15 minutes after exercise, or we can progress more gradually. I may guide a patient to stop exercise if pain increases by 2 points. The goal is to move better and move more. I guide with no burn, no earn for strength training, with the goal to create new healthy muscle with better fiber alignment and better blood supply. With each repetition, you may feel a gradual buildup of burn and the muscle belly of the muscle you're working. You can rewire your brain at any age. Use it or lose it. Use it and improve it. Neurons that fire together, wire together. And I love this meme. Oh, my cousin's friend's sister's girlfriend used to have that. She had magic healing moon fossils implanted under her skin, and now she's fine. You should ask your doctor about it. And this one, oh, I hope you can read it. Helium, will it kill the pain? No, but it's funny but when you scream, it's funny. I just had to include those. So usually when you leave physical therapy, PT does not stand for pain and torture, and most people feel better when they leave PT. I teach patients with chronic pain pacing, as the other Julie mentioned, to schedule pain relief into their day. For example, schedule in 30 minutes of rest with TENS after you go grocery shopping. How many of you have heard of a TENS unit? TENS is an acronym for transcutaneous electrical nerve stimulation. You place sticky gel patches called electrodes around the area of pain and turn the unit on for an electrical massage. I like the model TENS 7000, and I've taught hundreds of patients how to use it. Amazon sells it for $33. I am not an Amazon influencer, and I do not receive any money from recommending TENS 7000 unit. I share the preferred settings with you on the handout that you'll be getting by email. The settings make all the difference. Setting the mode to SD1, the pulse rate to 70, and the pulse width to 80. We think TENS works by stimulating bigger, faster nerve endings in the skin, which beat out the tiny, whiny C fibers that transmit signals to the part of the brain that determines threat and sets the alarm threshold. Many physical therapists have special training in dry needling. This picture shows dry needling with electrical stimulation. How many of you have heard of dry needling? Physical therapists often start with manual therapy to prepare the tissues for change. We may use kinesio tape to improve tolerance for movement, but PT modalities are always done in conjunction with the home program, including exercise. Massage and stretching can be a band-aid, treating symptoms rather than the underlying problems, but for us, they're often a catalyst for positive change, and improvement allow patients to tolerate new movement and exercise. The goal is to restore or train optimal movement and strength. Motion is lotion. Movement is the best painkiller on the planet. It improves mood, decreases stress, sharpens focus, improves sleep. The best pharmaceutical factory is between the ears. The brain produces chemicals that make us feel good. A 6-mile run stimulates endorphin release that's equivalent to 10 milligrams of morphine. Yet more than 80% of adults and adolescents do not get enough physical activity. Strengthening twice a week, aerobic exercise like walking 150 minutes a week, that's 30 minutes, 5 days a week. 10,000 steps is a great goal, but that goal comes from marketing. Research shows important health benefits of aerobic exercise with 4,400 steps. Physical therapy activity reduces the risk of falls and fall-related injuries in older adults. Stretching and aerobic exercise help to decrease pain in people with fibromyalgia. I may recommend starting with 5 minutes on a recumbent bike and add 1 minute daily, or 1 minute each day. So start with 3 days per week. Patients gradually work up to 30 minutes, 5 days per week, 150 minutes per week. If someone cannot tolerate walking, Tai Chi is mind-body active relaxation, and studies show it helps with pain and then can decrease fall risk by 40%. Tai Chi is done with neutral spine. If you're curious and would like to try Tai Chi for free, Patricia Corrigan-Culati, a Tai Chi master who lives in Waukesha, is offering a free class next Wednesday from 10 to 11 downtown Waukesha. I gave you her contact information on the handout that you'll be getting by email. She is trained in adaptive Tai Chi and can help anyone modify the basic moves so everyone can learn and enjoy the practice. I also included a link to Silver Sneakers video library. They also have good Tai Chi videos. You can actually, even if you're not eligible for Silver Sneakers, you can become a fan. So once you know that you're not eligible, they'll offer you a link to become a fan. They also have a free YouTube channel, and I find that their videos are the best. Friends don't let friends take opiates, so they're safer options. People have all about weighing the risks and benefits. Remember, words of reassurance are
Thank you so much. At this time, we are going to open it up for questions. So if you have any questions from any of the three presenters, feel free to drop it in the Q&A button or chat to whatever you're most comfortable with. But we do have one question already, so whoever wants to take it. But if a person is interested in trying alternative medications, where should they start their conversations? With a pharmacist or their primary care doctor?
So I can go ahead and start this answer. So it kind of depends. It depends on your relationship with both of them and accessibility. So a lot of patients will come to their pharmacist first to kind of vet out some answers and some possibilities. Primarily because they're easy to access. Most of your outpatient retail pharmacies, you can call and you can get a hold of a pharmacist right away or walk in and talk to them about the options. Others, though, are just a little bit more comfortable or have a longer standing relationship with their primary care provider, so may want to reach out there. But either would be appropriate as kind of a first kickoff to gather more information. Dr. Ricker, I don't know if you want to add anything more to that.
Yeah, so I train family physicians. Family physicians should be very comfortable with all of those alternative, duloxetine, gabapentin. There's new things coming out all the time for pain management. And it's okay to just ask your doctor, are they comfortable with it? And if not, can they refer you somewhere like, and the problem is they all call themselves pain clinics, but there's pain clinics who make their money by doing lots of very expensive, invasive things that don't actually have a lot of good data. And then there's other pain clinics that do really amazing, wonderful, integrative behavioral things, biofeedback and training and medications and, encouraging patients to use those topicals and all of those things. But yeah, again, a PharmD who really knows their stuff can really educate you on what to ask your doctor about, especially if your doctor is not an expert in chronic pain.
Awesome. Let's see. I don't see any other questions. Is there anything you want to leave our participants with? Like if you have one piece of advice, what would you give them before we end today's webinar?
Well, I wanted to let people know I put a link to FibroGuide. FibroGuide is a website put together by the University of Michigan, which has some of the leading experts in fibromyalgia and chronic pain syndrome. But I have used that website for years because it's really universally useful for patients with chronic pain. So it really focuses on that importance of physical activity, how to understand what's going on. There's a wonderful video on it where there's clearly physicians and there's patients in the audience. And after he's talked a certain number of minutes, he tells the pain patients, go ahead and stand up. You've been sitting for long enough. I bet you need to move now. And it's just such a gracious, wonderful attitude about just accommodating the needs of how people's bodies change. So I would encourage you to go ahead and look at that. It can teach you a lot about behavioral pain management.
Thank you.
I don't know that I have anything to add. I think some great resources were provided today on, alternative options for pain relief and how to work with opioid medications and, those individuals that are afflicted with opioid use disorder and addiction related to it. And remembering, I think Dr. Rickert really kind of hit it on the head, remembering what that patient is dealing with and, that there are a lot of things that can contribute to maybe what we would call bad behavior, but they're suffering from a disease no different than someone with diabetes or something like that. And so, being patient and understanding and kind as someone deals with and battles with recovery, I think is really important.
And when patients are struggling at our clinic, we work on helping them be more safe. So our conversation always is, you're really struggling with sticking to the safe behaviors with these dangerous pain options. And so we're going to work to reduce the risk. And so we'll see them more frequently. They'll give them fewer pills at a time. And yes, it's a hassle. And so, but we talk about helping them stay eligible for the higher risk pain management options, and it helps them partner better. And it also makes it easier for them at 2 a.m. when they have to make the decision about whether they're going to take another unscheduled pill, but then they're going to fail their pill check when they come in. It's easier to say no when you know there's somebody who's going to help you stay accountable. I always think of it as like, I give my daughters the privilege of sniffing their breath when they come home after they've been out while they're teenagers, so that they can easily say, no, I'm not going to have alcohol because my mother will find out. So it makes it easier to be adherent.
We did have a question come in. So why do my patients get angry when I try to talk to them about alternatives?
Because they want to feel better right away. And they become very passive. So people become helpless and they feel like the only way they're going to get better is if I take this pill. And you have to walk that fine line of saying, your pain is real. I think I heard somebody else talk about that today. And you deserve to feel better. And if I keep pushing this medication, you keep taking more and more of that medication, it's going to work less and less well over time. You're going to have more and more pain. So let's try some other things. I loved that Pain Australia video. That's what you can do about pain in 5 minutes or less. That's from Pain Australia. And it's just a wonderful, just kind of cheeky little explanation about what's going on and why are we asking you to be physically active. And that's a lot of the images that I use are what I use in my pain class with our patients, because they need to understand that their brains are tricking them. Their brains are telling them to rest and stay off of it and avoid, when really we need to decrease that brain sensitization. And that's why that physical therapy is so important. Moving your body is the ultimate treatment for chronic pain. Opioid medication really should only be in support of enabling the patient to move their body.
Yeah, and I think just adding to that is the stigma of what's out there right now. And so, like I had mentioned, it's a disease and an illness no different than diabetes, and yet people just feel like it's something that should be easily controlled. Oh, I think Dr. Edwards had mentioned, the pain's just in your head, or someone, making that comment. And so I think that also adds to it, is that when you talk about, let's talk about alternatives, people get very defensive. I'm not an addict. I'm not addicted to medication. I'm not one of them. Like they don't see it as a disease, and it's that stigma. And unfortunately our society and culture and what has kind of added to that, that leads to also that sensitivity when talking about it.
And that's where if you tell them the pain pill is only going to give you 30% reduction, so we need to add other things on top of that, because we're going to add 30% plus, a certain amount from quitting smoking and a certain amount from your physical therapy and a certain amount from using relaxation, then all of a sudden you're starting to stack up to pretty substantial pain relief.
And sleep is so important. Sleep is so important for chronic pain.
Yeah.
And if I could add one more thing, I feel like maybe people would become angry because they've tried physical therapy and it made them worse. And I think sometimes it's important to look for a physical therapist who does have special experience. It's totally different working with chronic pain than acute pain. So the new grads that graduate with their doctoral degree, they know exactly what to do for everybody with acute pain. But when it comes to chronic pain, those things are not going to work. And so I think doing some homework and trying to look for references. Most pain, like physiatrists, are going to know which physical therapists have that special training and experience working with patients with chronic pain.
Great. Okay, well, I don't see any more questions and we're almost up to our time limit. So I'm going to go back to my PowerPoint. Thank you again so much for your time and education today. One thing we didn't talk about is Narcan training. So I just want to make everybody aware that Waukesha County does have a grant for Narcan trainings and to provide free Narcan. So if you are a caregiver for somebody who is taking opiates, or you are prescribed opioids or whatever, this is a free training and you can get free Narcan. So if you want to find out when those training dates are, or where you can get that, the website is on the bottom and I'll drop the link in a minute. So that is, and what opiate or what Narcan does is it does, it reverses an opiate overdose. So Narcan is a really great tool and it does save a lot of lives. So that is available. This was talked about, Drug Take Back Day. So we just want to remember to get rid of unused medications. Again, in the thank you letter that I'll send you, I'll also put in a link where you can look up locations for that. And then this was also talked about. Aleve has donated these lock boxes. So if you are in need of one, you can pick one up for free at the ADARC, which is in Waukesha County. Mary Smith will have those. We do have 15 available. So if you could email her, just say you would like one and you can arrange a pickup. And again, this will be in your thank you email. And we did record, or we are recording this presentation today. So if you wanted to rewatch it, or if you know somebody that could benefit from it, we will have it up on the Your Choice YouTube channel, and I will provide that link again in that thank you email. So that is available to you as well. And then lastly, thank you everyone for joining us today. We do have a survey that if you could please fill out. When you leave the meeting, it should pop up and you can answer the questions. If you don't see it, that's fine. I'll also include the link in the thank you email where you can take it. If you take it, we are doing a $25 Amazon gift card drawing. Thank you to the Addiction Resource Council for providing that gift card. If you want CEUs though for attending this webinar, that survey has to be completed. And thank you to the Waukesha County Heroin Task Force prevention team, everybody that made this presentation possible today. And if you are interested in joining our prevention team or any of the pillars I talked about today, feel free to reach out to any of these organizations and we can link you to where you can get involved. So again, thank you to our presenters. Thank you to everyone joining us today. I hope everybody has a great rest of their week.